Good evening, councillors, officers and members of the public. Welcome to this evening's meeting of the Health Scrutiny Committee. Please be aware that this meeting is being recorded and live streamed for the Council's YouTube channel, and I welcome viewers joining us online. Please ensure that mobile phones are either set to silent or switched off for the duration of the meeting. Can I ask, is there any apologies this evening?
Thank you, Chair. We've received apologies from Councillor Leon Gibbs, and Councillor Chris Mundy is in attendance as a substitute.
Thank you. Move to the next item. Can I ask any members if they have any declarations to make in respect of the items on this agenda? Thank you. Move to the next item. Can I have a proposer and seconder to accept the minutes for the meeting that was held on the 16th of September 2025? Proposer? Seconder? Thank you. Move to the next item. I'm going to invite David Watts, Executive Director of Adults Health Partnerships and Housing, to introduce the report, please. Thank you.
Thank you, Chair, and thank you, members, for receiving the Northamptonshire Safeguarding Adults Board Annual Report for 2024-25. We report on the performance of the Safeguarding Adults Board on an annual basis. It's one of the statutory functions of the local authority to coordinate all safeguarding adults activity within its geographic footprint. So this report is important in helping members to understand the activity that takes place under the partnership, but also by the individual organisations that make up that partnership. We've taken feedback from previous years on some of the how we set out some of the report, and hopefully you will have picked up that there are two appendices, so the full report, but then also an impact report, which gives a bit more in-depth information into the activities of the particular subgroups that deliver the operational changes across the partnership. The statutory partners of the board consist of the police, the integrated care board and the local authority, but because the Safeguarding Adults Partnership covers the whole of the county, there's two local authorities involved, ourselves and West Northants. The chairing arrangements for the board consist of an administrative chair, which is usually one of the senior officers from one of the statutory partners, and then we have a co-chair who is an independent chair. We've decided on that route of governance because it gives that co-chair more of their days to spend actually digging down into the information that's being provided by the board, spend time with practitioners, spend time with people that use services, so that they get a much richer understanding of how we're delivering against the statutory responsibilities. It is an independent report, so it's not a report of the council, it's a report of the partnership. It's already been approved by the Safeguarding Adults Board, but it's presented to scrutiny in order for you to understand how we are performing against some of the key performance indicators in relation to safeguarding. It enables you to provide some feedback, which we can initially feed back to the partnership board, but it can also help inform Health Scrutiny's future ideas around areas of safeguarding activity that you might want to undertake a bit more of a deep dive into based on performance within the past year or so. I'm going to take it that the report has been read, and I'm happy to open up to members' questions. There will be some areas, depending on how detailed you get, that I may not be able to answer, particularly if it's in relation to the work of particular subgroups. I'm not a member of every subgroup, so if I'm unable to answer those, I will endeavour to get the answers from the respective subgroups. However, if there are if there's particular information that you want to know about how the board works, the activities that it's undertaken. If I've attended those activities, such as the week of learning, then I'd be more than happy to try and answer your questions in that space. But happy to take any questions from members.
Councillor Harrison.
Thank you. I'll kick off. Thanks, David, for the report. It's absolutely packed with information, and it's really good to see all the work that's going on. I want to dig in a little bit into the area of the SARS, the Safeguarding Adult Reviews, because there's just a few things in there that sort of jumped out at me that I'd quite like to just ask a few questions about. So first of all, I can see that the level of SARS has gone up again, in that the board received 20 this year, which is a large amount, and it's been going up over the last few years. I wondered if there was any particular reasons for that you know the board has become aware of. So be interested to know what the thoughts are around the increased level of safeguarding adult reviews. And just, I know I probably should know this from previously being on the board, but when you receive a SAR, because obviously it looks like only 3 of these are being reviewed at the moment. Is that because some of them don't meet a threshold and so they won't go on to be a full SAR? I think that's probably the case. So just a bit of information about that would be really helpful. I also noticed in the report about the second national analysis, which came up with 31 recommendations, which sounds like possibly a huge amount of work for the board to take on, depending on how that falls. I don't know exactly what the recommendations are and who would be having to deal with those, but it just concerned me a bit, because the other thing that bothered me was in the report it says that there's a lack of capacity within the Partnership and Business Office to complete SARS within 6 to 12 months. It sounds as if there's already a bit of a bottleneck, there's difficulty in terms of the resource available. There's been this second annual report, second national analysis, which sounds like it's giving more work, and I'm hoping it's not work that's already being done and repetition, but also that bit of information around why we're getting so many. Is it sort of referrals, people not understanding what should be referred and what's not, or whatever? And also, given that it sounds like the resource isn't there to get these SARs done within the time frame expected, I think it's expected anyway, are there any plans to deal with that problem and get some more resource? Thank you.
Thank you, Councillor Harrison, and through you, Chair. So, yes, I can confirm there is a set criteria that the SAR subgroup considers every referral against. And there's a different range of responses that we can have. So it could range from anything from an individual agency learning review all the way up to a safeguarding adults review. The criteria generally means that someone has to be in need of care and support. They have either died or suffered significant harm as a result of either neglect or abuse. And there's a couple of other criteria of which there's a little bit more ambiguity around. And it tends to be those where there will be an err on the side of caution, let the SAR subgroup consider it and consider what the most appropriate course of action is. We have monitored the number of safeguarding adults reviews, referrals that we do get. We're not out of kilter for our size of population in comparison to the region. All areas have seen an increase. Most of it is around awareness. So if you think that the original safeguarding process were probably implemented in about 2004, We're 20 years into that. There's been lots of learning, some really positive learning out of safeguarding adults reviews. So there's a much greater awareness of statutory partners. There are a number that don't get through to safeguarding adults reviews. Many of them we do undertake light touch reviews on because we still think there's an element of learning. However, it doesn't meet the criteria as set out within statute to go forward for a full safeguarding adults review. On the analysis, I think, generally speaking, what you will find is our quality and performance subgroup will have reviewed that. As you will recall from your time on the board, we have twice annual meetings which look at the board priorities, activity that we need to undertake, and we will take into consideration some of those additional things being brought up through the analysis. Much of it is replicated in what we've seen through our safeguarding adults reviews or what we've seen around, for example, learning and development needs moving forward. However, yes, we do have tight resources in our board function. It's dependent on financial contributions from all of the statutory partners around that. We haven't seen a significant increase in that, but we do find that with a certain element of prioritisation throughout the year, that we can meet the majority of activities that we need to. It tends to be that it is complex safeguarding adults reviews that tend to bridge that 12-month period. So there could be a lot of partners that are involved, new elements that come out as part of the investigation that then there's a request to expand the scope of the safeguarding adults review. So there's usually a justification as to why we may go above and beyond that 12-month period. But we're also really cognizant that people who've been affected by it, so perhaps relatives of someone who may have lost their life or may have been seriously injured, or the individual themselves, but also staff who've been involved in that case. It's really important that we try and conclude those safeguarding adults reviews quickly but accurately.
Thank you. Yeah, and I remember from my time that some of the safeguarding adult reviews were incredibly complex. So I can perfectly comprehend that. Just as a matter of interest, since this 2024 to 25 period finished, have we had any safeguarding adult reviews reports since then? Do you know?
I'd have to double check the timings of when they've been published. It always confuses me because we're looking at the previous year. Sometimes some of them have started in the prior year. So, for example, if they were referred in the January, February. So I can certainly look into that and I'll circulate it to Raj to pass on to you.
Yeah, thank you. I get similarly confused by what the dates are and what they refer to. And then just finally, so from the point of view of us as a scrutiny board and the sort of issue around capacity within the Northamptonshire Safeguarding Adults Board, it sort of feels to me like it's something that perhaps more resource is needed, and I realise it comes from all the different partners. It would be something, I think it would be good to come back, maybe and see what's gone on in the intervening period, perhaps after 6 months, and just see what board members have thought about how to resource it better and how to be able to do those safeguarding adult reviews maybe a little quicker, because I know that as you say, they are complicated, and I imagine the business unit is constantly having to chase people for, the work that needs to be done. So I think it'd be good to know if there's could be an improvement in that capacity in the future.
Thank you, Councillor Harrison, and I'm quite happy to take that back as if the Scrutiny Committee decides at the end of it that it wants us to feed back particular requests to the Safeguarding Adults Board, if there was a recommendation around considering whether there are sufficient resources for the board management office to function in the way that it needs to, I'd certainly be happy to feed that back at the next Safeguarding Adults Board.
Thank you, Councillor Harrison and David. Any more questions? Councillor Pengelly.
I think it's a great report. When you look at the finances equated to the work you do, I think they're very, very low. I would expect the work you do, there'd be a lot more financial sort of money going your way, because I do understand how important the job you do. And through being a councillor, through being at work, or through your job, through many other reasons, you could go in the line of having to safeguard somebody, get in touch with you, and that could be through somebody being bullied or harassed, or you don't think they're being looking after themselves too well. The one thing I found, because I've used it many times as a councillor, is you don't come back to the individual who puts a safeguarding request in. Is that a data protection thing? Because sometimes you think to yourself, I wonder what happened to Mrs. Jones or Mrs. Smith. I put that one in. I wonder if she's okay now. And you don't know. So is that just a safeguard, a data protection thing, David?
Thank you, Councillor Pengelly. So just on the finances, just to be really clear, the finances which are set out in the report are the costs of administering the board and the activity of the board. What you will find is there is lots of officer time which is resourcing in kind from across all of those organisations. So, for example, you have senior officers from the police that will chair particular subgroups, same from the ICB, same from the 2 local authorities, and a number of practitioners as well. So if you were to quantify the whole resource that went into functioning the board, it would be significantly greater than that, but this is the amount, sort of like the administrative costs. On safeguarding referrals, you are right, sometimes we do not have permission to share back the outcome of that activity. So we generally seek permission from people at the point where we make contact with them. However, that doesn't stop you asking the question, and we will come back to you if and clarify whether we have permission to share any further information or not.
And one it's very difficult to get through to people on the phone, and I understand how busy people are, and you try and go through on the phone, and you know yourself, it's 101 different prompts until you get there, and sometimes you think you've got to get through to somebody. So I do it all online, and online seems to be asking more about me, who's putting the complaint in, or the safeguarding in, than the person you're putting it about. And if you look at the form, I think it's brilliant. It's very, very easy to use, and it's very smooth as well, which is very, very good. But sometimes you think, why are they asking me all this about me? It's about this person I'm worried about. But yeah, thank you very much.
What I would recommend for all councillors is, if you have put a safeguarding in, please do use the members' inquiries process, because you will then circumvent the having to follow the referral process within the safeguarding adults procedures which you would need to follow. So if you use members' inquiries, then we will endeavour to get back to you. However, it will depend on the lead agency. So it's not always the local authority that is the lead agency, and we may have to liaise with, for example, the ICB or police. Okay.
Thank you, Councillor Pengelly and David again. Any more questions? Councillor McLean.
Thank you, Chair. When you receive a notification of a safeguarding problem, whether it be the police, NHS, teachers or otherwise, is there a bit of a time lag between getting these reports and action being taken, or do we have a sort of immediate action line which then sort of, I imagine, jumps into place and takes this on?
Thank you, Councillor McLean. Yes, there is. There are different levels of triage that will be undertaken by our safeguarding practitioners. Some will require an instant response, so we have had circumstances where we've been contacted and we've safeguarded the individuals exactly, within hours. There will be others where the risk has been immediately removed but still needs investigating, and activity is required around that. What you will tend to find is that protection plans that are put in place can stay in place for a long period of time, particularly where we have concerns around things like coercion or where the alleged abuser may live in the same household as that individual. So we have protection plans that may stay for a significant period of time until they're stood down in that sense. But yes, the response times will be dependent on the severity of the concern coming in. Quite often within that triaging, we determine that it isn't a safeguarding concern. So all of the local authorities in the region have had challenges around ambulance referrals for safeguarding activity, which is being addressed at a regional level, in that they have tended in the past to refer everything in as a safeguarding. So, for example, if they find someone fallen at home, they would refer it as a safeguarding. So, well, they're not safe at home, so they need safeguarding. So there's been a bit of training for the ambulance services around what is a referral for care and support needs versus what is a safeguarding activity, which is predominantly around abuse, neglect or self-neglect.
Yeah, I think talking about that, I mean, do we have like a sort of scoring system where those who attend a safeguarding situation will have a sort of, a scoring system which will tell you how serious it is or, how much lighter it is?
There isn't a different, so it's done on more of a contextual basis. So you look at the context surrounding the individuals. There isn't a pro forma to go through where you tick X, you tick Y, it adds up to a certain score for safeguarding adults. Within the field of things like domestic abuse, there is. So there's a system called a DASH, so domestic abuse, I can never remember the title of it, I'll get it in a minute, come back to me, where that is based on scoring. But what we tend to find within a safeguarding context is there are so many elements that can impact on it that you would struggle to apply a strict format to it, because there can be lots of different things going on in someone's life. There can be lots of protective behaviours, but that doesn't mean that someone hasn't been abused. It could mean actually they're safe at the moment, but there could still have been abuse that has been perpetrated that needs to be investigated. But that would be triaged lower than someone who is still at risk of that abuse. So
I think the reason I ask is because it was a personal situation that I knew of where there was an abuser, somebody being abused, and the abuser had left the house but then was threatening to commit suicide and stuff like that. So it was a sort of like a two-level thing. And initially the police came to deal with this. And so for me, I never had any experience of this itself, so that's why I'm asking the questions to an extent.
Thank you, Councillor McLean and David. Paul? Councillor Brooks, sorry.
Thank you, Chair. You say that when Councillor Pengelly said that you report online and they ask you tons of questions about yourself as opposed to the person that you're reporting. Do you not find that that's a barrier to people reporting? Because not everybody wants to put their name up front, and I realise it's probably fairly it's probably their name's not going to be put forwards, but they don't see that when they're sat there writing it, thinking, if he finds out I've told that he's battering his wife, I'm going to get the repercussions from that. Do you understand what I'm saying? And so someone says, I'll cancel it. It's just my thought, really. Do you not find that a problem? No.
We tend not to. So the majority of referrals that we get are referred by organisations, less so by members of the public. what we would tend to find is that members of the public would first go to the police, and it would be the police that would refer through to us. But there are, we've got lots of processes and standards around protecting third parties and third-party information that is obtained through the referral process. So that doesn't mean that an abuser might not find out who would raise those concerns, because generally, it's likely, if it was to be a member of the public, it's likely to be a neighbour or a member of the family in that sense. But we do have safeguards to put those protections in place. The majority of our safeguardings are more about neglect, more about, breakdowns in carer relationships, those sorts of things. So they're almost cries for help at times as well. So our practitioners are very often working with perpetrators in a positive way, which is about how do we take some of the pressure off you, for example, in your caring role, so that you are not becoming frustrated, you're not tired. We don't treat perpetrators as a default as criminals in that sense. It's about trying to work with and find the best solutions. What we often find is the person who is subjected to abuse may not want anything to happen to, for example, a friend or a relative, because of the relationship that they've got with them. So it's about trying to work in a positive way to improve the interactions there. But yeah, we have safeguards to protect people who are referring in, to make sure that third-party information is not disclosed, and particularly if people say, I do not want that information or my details disclosed, then that will be recorded on the file, and even within, for example, subject access requests. So if someone was to say, I want to see any files held on me as a perpetrator of abuse against vulnerable adults, we would have to redact that information, which would all be dealt with through our data protection team and freedom of information team.
Any other questions? Councillor Howes?
Thank you. I'd like to just go back to the SARS, please, if I may. I'd like to know if you can give any examples of where recommendations have been successfully implemented, and what the process is to ensure that A, they are implemented, and B, that they continue to make a positive impact.
Okay, so pretty much every SAR there will be a list of actions that need to be implemented. Many of them are about learning, and what you will often see is that we have evidence around that. So you will see improvements within our training programmes, so multi-agency training. We have particular weeks of learning where we'll bring practitioners together, we'll present back findings from safeguarding adults reviews, and have workshop activity around how can we improve processes there. The governance that we have for making sure that any recommendations are implemented sits with our SAR subgroup, so they monitor the action plans, make sure that there are clear deliverable timescales against that, and report that back to the Safeguarding Adults Board on a periodic basis as to how we're progressing against those.
Thank you, Councillor Howes. And David, any more questions? Councillor Duffy?
Yeah, I just want to inquire, how does the adult system pick up children that are coming out of children's safeguarding situations? Is it an automatic transition, or do you lose people? I would be aware that a child could move out of a home that's been abusive and you could lose track of them. Is it something that's picked up automatically between children and adult services?
I wish I could say to you that it was something that was picked up automatically. What it can be difficult to understand is there's two legislative frameworks and they do not neatly dovetail. So safeguarding vulnerable adults activity is framed around people having care and support needs. Quite often, children that have been in abusive relationships within their family may not have adult social care support needs. So it wouldn't necessarily get picked up through adult safeguarding. What we do have is a process called the Adults Risk Management process. So where a organisation is concerned about the vulnerability of someone, but they don't neatly meet criteria, any of those organisations can call an Adults Risk Management or an ARM meeting that is set out within our procedures, which pulls together all partners that have an interest in working with those people. They may have concerns about it, to make sure that all organisations are doing everything that they possibly can, and to ask the question, if we could do more, whilst it may not be within our criteria to do more, is the benefit of doing that likely to outweigh the harm that could happen as a result of not intervening in those circumstances. So those legislative barriers do cause some challenges, and you know, a 17-year-old that's been sexually abused by a relative will be equally as at risk when they're 18 and a day in comparison to when they were as a child. But the legislation that covers them and protects them is very different. But we do have some of those safeguards in place to try and manage that. I think what you will see is there have been circumstances across the country where people have fallen through the net, and we're constantly looking at practice. We have a process called Think Family, which is trying to think about, you know, these issues do not go away. Family issues, family dynamics do not necessarily change because of a birthday. But it's always work in progress. It's always something that we have to be cognizant and mindful of. We try and make sure that we build it into our safeguarding training about making sure that you don't just let someone drop off, that you are always thinking about, is there someone that's more appropriate, despite the fact that that person may be exiting my services. Certain examples where we have seen that has been the difference between children's mental health services and adults' mental health services, where there isn't necessarily a clear transition through that. So that's also part of the work that we're trying to do in partnership with the Integrated Care Board and with NHFT, who provide our acute mental health services as well.
Thank you, Councillor Duffy and David. Any more questions? Councillor McLean?
Just a little bit of circling back here. When we were talking about safeguarding adults, and one of the things you mentioned was that, say, for instance, an elderly person has fallen over in their house. What processes are in place actually to identify these, older people who are living on their own? And obviously, maybe there's nobody goes to see them often, and how are they sort of looked after?
There are multiple referral routes. So, for example, GPs will know about the referral processes. What we tend to find is that older, frail people are usually in contact with some of the services before they come into contact with adult social care. So it might be that we receive a referral from an acute hospital when someone's had an admission. They might have had some sort of treatment whilst they were there, but their needs have been identified. So we have a team that provides support into the acute hospital, and we also work with primary care and district nursing to try and pick up some of those people. We also commission a service called Support Northamptonshire, which is a voluntary sector provided service. It's supported by Public Health as well. And that's about trying to identify people earlier, and it's almost like that no wrong front door approach. So someone may approach a service about housing concerns or struggling with managing their finances, not knowing what benefits to claim, and that can often be a route of access into that. What we would also say is you as elected members will often be people who are respected within the local community. So knowing enough about where to refer into or how to ask the right questions is one of those key bits from your perspective. And we do try and promote our adult social care activities on our website, through social media, to continue to raise awareness out there. We also have what called place-based partnerships, so we are trying to make sure that a lot of our services are based around communities, and particularly where we know that we've got a higher proportion of older, frail people, the sorts of services that we will locate around that particular locality in the longer term will probably be more focused on supporting and identifying people who are frail, isolated, and looking at how we can better shape those services. Whereas perhaps in some of our more urban areas, it might deal with other things like deprivation, substance misuse, some of the other issues which are perhaps more prevalent within our urban areas in that sense. So again, a lot of it's always based on, do people know the right place to go? And we're always trying to understand different ways of identifying people. Particularly, we are exploring the use of artificial intelligence to look at data that we hold and flag up people that might become a risk within, for example, the next 6 to 12 months of having adult social care support. And that's where we're talking to organisations like the NHS to say, well, actually, if we combined our data together, albeit with the right protections in place, so that people know that their data is being combined, you can use a lot of the learning from people's previous experience, which might say, well, we've seen an increase in the number of times that they've contacted their GP. Usually when we see that pattern of behaviour, we might see someone approaching adult social care for support within the next 6 months. And it tends to be around these sorts of issues. Might be around mobility, might be around continence. It might be around not being able to manage meal prep or manage medication. And that enables us to then start thinking about how do we then reach out to those people and give them information in a proactive way rather than them having to search it out.
Thank you, Councillor McLean and David. Any more questions? Councillor Geary.
Thank you. Really interesting report, and it's extremely complicated. You spoke about AI as a potential way of making decisions. You talk about experience, you talk about context, and you talk about legality as well. So there's a lot of separate elements there. Something that came up to me in this report with regards to safeguarding is it must be very difficult at times to ask for help. What are we doing to make that sometimes quite tricky task easier?
Thank you. And you're absolutely right, it can be. And I used to work as a social worker and actually met the same gentleman 5 times before he said, yes, I do want your help. 3 of those times he fractured his hip, but refused all support. So there's something about persistence. There's something about it might not be the right time now, but there might be a right time in the future. So don't count people out just because they've said no once. And quite often there is someone within that person's life who will be able to have a better conversation. So within adult social care, we have an approach called 3 conversations. And we take a strengths-based approach. So we look for the things that are strong in people's lives, not what are wrong in their lives. So we look for, they may have a neighbour who's really involved. And it might be that neighbour who is better at having the conversation with them about agreeing to accept some support. Or it might be that actually, so in some circumstances, it has been, GP or district nurse who's going in and doing things. Or it might be a cleaner. So it might be someone who's providing domestic support. So it's about trying to make sure we have the right information. It's about being persistent. We always tell our social workers and our non-professionally qualified assistant social workers to be curious. to be interested in people. Yes, they're busy, but you need to be curious and interested to pick up on the issues which they may be talking about. So it's a little bit of an art as well. That's why we're always trying to attract new people in who like talking to people, like getting to know people, can build up productive relationships with them, because those are the people that will be able to make the right sorts of connections. And again, we use our voluntary sector organisation. We also use Carers Northamptonshire, because quite often it will be a informal carer, so a relative who's perhaps struggling in managing care and support needs, that becomes the person that says, we need help, not necessarily the person themselves. So lots of different ways of potentially tapping into that. But the main thing about creating the right culture within our workforce, about being curious, being interested in the people that they meet, and trying to find those different ways of broaching those difficult conversations with them. Let's face it, perhaps the last thing a proud working class man might want to talk to someone who's coming out to see them is about the fact that they might have fecal incontinence or urinary incontinence. So trying to have those different sorts of conversations and recognise that sometimes you're not the right person to be having that conversation is a big step to take, and looking at who within that person's network might be the better person to have that conversation.
And one further question is, do you anticipate any groups of people in the future that are like or more likely to become in need of safeguarding? I think of mature people clearly as an example. Are there any other groups you see expanding perhaps more rapidly than the norm?
So we are seeing increases in people with sort of like universal mental health concerns. So that has been something which we are monitoring quite closely. The eligibility is a bit ambiguous around mental health, because what you tend to find is most of the treatments are things like talking therapies or medication in that sense, which will be health-based. But it's about how we can create the right sort of support around it. It may be about helping out with other aspects of that person's life that sort of manages in that space. And the other bit which we have to recognise is that health service is very good at supporting people with complex needs in a way that perhaps in their 70s and 80s we weren't able to. So those people may have died at a much younger age. So we're starting to see more people with quite complex needs coming through, particularly people with learning disabilities. However, that's something which our teams are very used to working with and looking at how we manage risks moving forward. I think the other thing which we have to be cognizant of is there's probably a lot more prevalence, or certainly a lot more identification of people who have substance misuse as a part of their the concerns or issues that are surrounding them. So that can be a factor that increases risks to people around vulnerability. So making sure that we're training our staff to understand different ways of working with people with substance misuse issues is something that we're focused on as well.
Thank you. Thank you.
Thank you, Councillor Geary and David. Any more questions?
It's not a question, it's a comment that when David gave an answer to the previous question, it started going towards the job I do. And so I wanted to just say that I have got a non-pecuniary interest in supporting people once they've been discharged from hospital, and sometimes they come to the team that I work with. So it just, I thought, I'm going on to, and when you're given loads of different answers on different things, it widens things sometimes. So I just thought, if that could be recorded, please. Yeah, it's not pecuniary in any way.
Okay. Yeah. Thank you, Councillor Pengelly. Does anybody have any more questions? No? I'd like to thank everybody, and thank you, David, for some very informative answers to some of the queries. Thank you. I'd like to move on to the holding recommendations. and it is recommended that the committee receives a mid-year update in May 2026, outlining progress made against the 2024 to 25 strategic priorities, including measurable outcomes from safeguarding audit reviews and audit activity. It's also recommended the committee is provided with a briefing within 6 months on system-wide responses to self-neglect and complex safeguarding cases, including outcomes from the Self-Neglect Summit and implementation of related learning. It's also recommended that NSAB shares with Scrutiny in its next annual report an evaluation of engagement effectiveness across statutory and non-statutory partners, including feedback from practitioners, voluntary organisations and residents. I'd like to thank members and officers for their contributions and move on to the next item. Sorry. Councillor Harrison.
Thank you. I wonder if I could just add a recommendation that we get some feedback again on the issue of the resourcing of the safeguarding adult reviews, that we talked about earlier. And David kindly said that he would take that back to the board as a recommendation, because there's a little bit of concern around the timeliness of some of the safeguarding adult reviews, and that they're obviously quite complex and possibly in need of a bit more resource. So if we could get a report back about that, that would be fantastic, if the rest of the committee agrees.
Thank you. I need a proposer and a seconder. Thank you. Can I ask members if they're happy to note the report? I'm going to move on to the next item. And I'd like to welcome Jane Bethia, Director of Public Health. If she could introduce her report, thank you.
Thank you, Chair, and thank you, committee members, for your time this evening. We brought this same issue this time last year. Winter preparedness is an extremely important issue. The key issues within it really fall into 3 areas. So one of them is, what do we anticipate from a health perspective that's going to put pressures on this year? So people will know that things like flu, influenza are a big particular issue at this time of year, but also we have other things like norovirus, which for some of us is that awful bug that ruins Christmas and gives you sickness and diarrhea, but for some people it can be extremely dangerous, particularly if they've got other health comorbidities and vulnerability. So we know, for example, that from a flu perspective, we're anticipating quite a difficult season this year. We tend to get a lot of our information from Australia and what's happened there, and you'll have seen over the summer, over our summer, but their winter, that they've seen significant issues in Australia, which always means we are concerned about that. And so part of the discussion tonight will be about vaccination, something that's really, really important in terms of protecting people's health, protecting people's families, but also protecting the health and social care system. The health and social care system is always under pressure, but during winter months it becomes particularly difficult. And what we're going to be talking about this evening is some of that planning, but also how through things like vaccination we can make sure that we are protecting the system as much as we possibly can. The final area really is environmental. So we know this time of year brings particular issues from an emergency planning perspective. So I've been here for 2 and a bit years, and there's been a number of floods in that time, for example. And we've got Ian Smith with us this evening, who's going to talk a little bit about emergency planning and preparedness around flooding and other extreme weather incidents. So with that, I will now pass on. I think Sarah is starting with us this evening. Thank you, Sarah.
Thank you, Jane. Good evening, councillors. I'm going to start doing a presentation on winter preparedness, as Jane has already discussed with you. So winter preparedness will basically cover this evening our key functions for the health protection team, our specific requirements of winter planning, but also the core activities locally and why these are important. So the health protection core functions are relating to effective delivery of local health protection services and that require close partnership working between the UK Health Security Agency, so UKHSA, our NHS, so that's on a national, regional and local footprint, and local government, and amongst others, core public health protection functions expected with the local health systems include communicable disease control, emergency preparedness, resilience and response, risk assessment and risk management, incident and outbreak investigation and management, monitoring, surveillance of communicable diseases, infection prevention and control in health and care settings in conjunction with Kettering General Hospital, monitor all aspects of immunisation and vaccination programmes, and environmental public health including chemical, biological and radiological hazards. So with winter preparedness, we are constantly looking and working with our health and social care system, which involves an awful lot of partnership working. We're constantly reviewing national and local guidance. Winter pressures was always something we saw a very definitive between summer and winter, but I have to be totally honest, I feels that it should be all year pressures now. And as for someone that still does the occasional hospital shift, I do see that. We always need to be prepared. So when we talk about health and the social care system and partnership working, we daily attend the urgent and emergency care system calls, and that's with our adult social care colleagues, our community hospital colleagues, our acute colleagues, so both hospitals, and also our community mental health teams and our mental health hospitals. During those conversations, we discuss hospital capacity, bed management, the levels of acuity of patients that they are seeing, ambulance waiting times, ambulance handover times, and if we are, as a health protection team, identifying anything in the community that could cause an increase in hospital admissions. We also discuss the flow of the hospitals, so that's patients coming through the front door and patients being discharged. And you will hear this now more in the news because hospitals are increasingly under pressure. We also work with our primary care colleagues as well, and they also will attend urgent and emergency care calls. With guidance, we view all the latest outbreak management guidance. So it's the UK Health Security Agency's national guidance and regional guidance, and we make sure that that's taken into account when we write our local policies and guidance and standard operating procedures for disease outbreaks. As we've said, winter pressures should really be all year pressures. But as a preparedness for all of this, so far the health protection team have taken part in 3 exercises this year. So exercise Tangra and Solaris have fed into the latest national exercise that we've taken part in, Pegasus. And this is looking at how we shape the nation's response to future pandemics, because there will be another one. So it's lessons learned, what have we learned, how do we take this forward, how do we make our responses better and safer. Okay, just going to go on to the next slide. So with immunisations, incredibly important. So why do we vaccinate? It's basically the most effective way to prevent many infectious diseases. It helps protect us, so selfishly, myself. It helps protect my family. It helps protect my children. It also helps protect my community. And that's the same for everybody who has a vaccination. It also helps eliminate some communicable infectious diseases. And then we start to see low case rates of that infectious disease. Who do we vaccinate? Well, we vaccinate all our eligible cohorts. So whether that's the seasonal vaccination programmes, our childhood immunisation programmes, our adult immunisation programmes, and even to include travel vaccinations are incredibly important. Where do we vaccinate? So GP practices, our pharmacies, so our community pharmacies, our outreach or mobile vaccination units, occupational health, and also our school immunisation teams. Going on to infection prevention control. So what is this? So this is evidence-based. It basically prevents patients and health workers and our communities, ourselves included, being harmed by any infectious disease. Outbreak management relates to practices that prevent transmission and spread of these diseases. Basically, we have to break that chain of infection to stop that transmission of that disease. We need to understand how that that infectious disease travels, signs and symptoms, how it's spread, what countermeasures do we need to put in place to risk assess, to look at the impact. People think infection prevention control is around hand washing. Yes, absolutely, but that's just one part of it. There is also wearing the appropriate PPE, having the appropriate training to wear that PPE. We also look at cleaning schedules, cleaning materials, what areas are cleaned, what areas are not cleaned. We also look at laundry processes. So it's a whole big picture when we talk about infection prevention control. And what we use are the 10 national standard precautions for infection prevention control. That's my guidance, my guidelines. I will never deviate from them. I cannot deviate from them. So when we talk about countermeasures, vaccination plays a big part in that, but also things alongside antivirals. You may have seen that the government have recently decided, along with our Chief Medical Officer, that antivirals should now be routinely prescribed should we start to see an increase of communicable infectious disease in, for example, a care setting. That then reduces the risk of admission into hospital. And also things like swabbing, really important. We like to know what the virus is. We like to know what strain it is. And from that information that we receive with regards to swabbing helps us then put into the plans to put control measures in place to stop and break that chain of infection. Okay. So emergencies and major incidents, as Jane has already described, we've had flooding and quite destructive flooding at times where we've had to evacuate residents within our communities. We've had some heavy rain recently. We've been meeting with our emergency planning teams to make sure that we are ready should we need to respond to any areas of flooding. So our health protection team is part of this emergency planning response. And like we've said, it can be health related, it can be flooding, or it could be, for instance, a major fire. We are also starting to identify impacts caused by our warmer summers and the change in disease patterns and the spread of these diseases. So, for example, in some of our European countries, we've seen mosquitoes, things like that we've never seen before in European countries. So because of the changes into the environment and our sort of planet becoming warmer, we're starting to see things, infectious diseases, coming into very closely to our country. So it's something that we need to be incredibly aware of. and also things like our what we call vector-borne, so our tick bites and things like that as well. So really, really important that we monitor. And what we do on a regular basis, it comes to us weekly, is that we look at across different countries, continents as well, what diseases and outbreaks they're starting to see, and potentially how it could come into the UK, and if it did, how would we deal with it? Okay, so that's the first presentation. Would you like questions done now, or would you like questions when we've completed all of the presentations?
We'll do some questions now.
Thank you.
Councillor Mundy.
Thank you, Chair. I just wanted to ask you about vaccinations and what we're doing to increase the uptake of vaccinations, because obviously there's a great deal of scepticism regarding vaccinations, and it's more often than not fueled by misinformation, disinformation online, and I've certainly seen it myself. And indeed, last year, the UK Health Security Agency says there's been a resurgence of measles, which we thought we'd nearly eradicated in the UK, and that was, they're saying, is due to vaccine scepticism. So my question is, what are we doing to increase uptake in those communities? Are we doing any targeted approaches? Do we have any data on it? Thank you.
Okay, so in one of the following presentations that's from the ICB, we will be going and we will be explaining what we're doing around those vaccination target groups. But what I can say is that we're looking at introducing things like vaccination awareness training via the Royal Society of Public Health, and this is potentially being could be rolled out to community leaders, yourselves as councillors, so you can start to have those really informed conversations with our hard-to-reach populations, so we can start to myth bust basically around, social media, things like that. But we'll go on to more of that in the presentation. With regards to measles uptake, we're currently, so there's 2 vaccinations that are offered with measles. So we call them MMR1 and MMR2. MMR1 is currently sitting at 89%. MMR2 is currently sitting at 86%. The World Health Organization target is 95%. But what will be happening as of the 1st of January, there will be a big change to the childhood immunisation schedule. So MMR2 is usually given at 3 years, 4 months. It will now be given at 18 months. And it will also be included with the varicella vaccination, which is the chickenpox vaccination. So it will now be called MMRV, just to make things a little bit more complicated. So from next year, MMR2 will be delivered at 18 months. And research is showing that there's no difference with it being given at 18 months than at 3 years, 4 months. So hopefully, as well, with it being brought forward, the uptake will be a lot better and a lot higher.
Thank you very much.
Thank you, Councillor Mundy.
Am I able to respond as well to that question, please, Chair, if that's okay? I just wanted to pick up on your issue of vaccination hesitancy. And you made a very valid point around misinformation that is out there that causes really big concerns. And obviously, I'm old enough, you'll be shocked to know, to remember the Andrew Wakefield scandal and just how hugely that impacted on parents and how that impacted on people's confidence in vaccinations. And we're still coming back from that. We're still having to deal with that. But we are seeing the uptake go up, and I'm really heartened to hear the national move to changing that schedule to make it easier. The other vaccine I just wanted to mention is human papillomavirus, so HPV. So HPV is a really nasty, annoying bug that the vast majority of us will have at some point in our lives, and it causes probably 100% of cervical cancers and about 50 to 60% of head and neck cancers. And this is a job we've got on our hands now, is to make sure people understand that having that vaccine in year 8 at school, which is where it's now offered, can be hugely important for your future health. We're already seeing the impact of reduced numbers of cervical cancers in the young women who have gone through that, because this first came out in 2004, was it 4? So we're already seeing the impact. So as councillors and members, being part of that kind of armoury that we have to have that conversation with people about how important that is really, really valuable. So, if you get the opportunity, we would very much value your assistance in that area.
Absolutely.
Thank you, Jane. Councillor Harrison.
Thank you, Chair. Yes, so I was interested in when you were talking about the different viruses that are going around at the moment, and obviously monitoring those through swabbing to find out not only which viruses they are, but which strains of those viruses they are. And obviously we can all remember doing plenty of swabbing during the pandemic, but obviously, and from time to time, I still will do a COVID vaccination. Sorry, not vaccination, a COVID swab when I'm not very well, and I did actually have COVID a few weeks ago. But we don't actually swab for anything else at home. So it's interesting, because it must mean that you're getting just partial data from a certain section of society rather than across the board. And I don't think GPs swab either. I don't think it's routinely done in any forum other than perhaps your world. And so I'm just interested in whether there are any moves afoot to have to make it more make it easier to identify what viruses people have, just across the board, and to get more data about that in the future.
Not that I'm aware of. Having said that, though, IPC guidance, so infection prevention control guidance, states and has now gone back to pre-pandemic guidance. And if we're having to go out to a care setting or anything like that, we swab the first 5 symptomatic patients. If those all 5 come back as positive for either flu A, flu B, COVID or RSV, then we will assume any other residents that become symptomatic will also have that virus.
I guess that makes sense. Thank you.
Thank you, Councillor Harrison. Any other? Councillor Pengelly.
Yeah, it's just first and foremost, I think this year, with the inoculations and the flu jabs and the COVID jabs, it's been absolutely brilliant. They're all out into chemists. It's just been absolutely brilliant. And my wife queued an hour for hers, and I just went in and got mine done straight away, which is really, really successful, and congratulations on that. One of the issues we have is the false news going about that if you get these jabs, this happens to you, that your arms fall off and all this sort of crap. How do we counteract that? Because there is a large swathe, there's a large group of people saying it, it's on social media, people believe it. What information is there for us to counteract it? Proper information, not what Susan says around the corner or Jimmy says in the pub, because this is really important, because if people don't get the jabs, then it can increase and spread. We all know what happened with COVID. And the second thing, and I don't know if it's coming on later or not, but you've put £2.2 million in case we have another outbreak, and you said there is going to be another outbreak one day. Hopefully this is not as bad as we had last time. What was the cost of the council last time? Is £2.2 million enough? And do we need more? Because I thought the amount we spent last time was a lot more than £2.2 million. And do you need to go to the executive? And I don't know if it's a criticism, but take it, it's not. On 7.61, you said the executive haven't looked at this. I don't think it's a criticism, it's just the fact that they haven't looked at this. Yeah. Or yeah.
Sorry, Councillor, I haven't looked at...
Well, on 761, what it says is the routine winter planning activity is not being considered by the executive.
Yeah,
it wouldn't be anyway.
No. It's for information. Thank you for raising that. So I'm just going to deal with your first question first, but Sarah might want to come in. You're absolutely right. getting the right information that's trusted is really key. And unfortunately, there is a lot of information out there that can't be trusted. And also some people will be attracted to information that meets their current narrative rather than something that actually challenges it. So what we always say is go to your trusted places. So the NHS website is fantastic and it covers everything you need to know. I mean, I always think it's something that everybody should have on their favourites because it tells you things about symptom management, it tells you about vaccinations, it also tells you about risks and all of that other information, and that's really key. I think it's going to those trusted particular sources. If I can just talk about the money that we have inside for any sort of health protection emergency. So, good timing because I'm on the magic course at the moment for emergency planning. And you are absolutely right that it would have cost an awful lot more than £2 million to pay for all of the costs that the whole system needed to cover for COVID. What it allows us, though, is rapid deployment of things should we need it. So we know, for example, that if we suddenly needed PPE, at some point, a really good source of PPE would come on through a national line, essentially. But this puts us in a position to be able to move more quickly on things like that. And we do occasionally use that money for other things. So, for example, under legislation around TB, so tuberculosis, we might need to provide somebody with housing. If they are, for example, rough sleeping, and they have infectious TB, there is a requirement through NICE guidelines for us to work with our ICB partners to support that person's housing so that they don't spread it to other people. TB is horrible. We don't want that. So we can use it for that as well. But we always want to protect. It's about protecting the population. So we think we've got, and Sarah, you might want to talk about, because you're doing some work about how you might deploy that. But I think lots of other areas don't have that. So it's actually something that we're quite proud that we've done that. Yep. So that we've got that. And I think the exercise Pegasus that we've been we're a focus area for exercise Pegasus, which basically means we've had to do a huge amount of work on our pandemic preparedness over the summer, and now we've been in this live exercise for about 2 months, I think it's been. I've chaired some strategic command groups, etc. for that. And that as well, I think we've learned so much from that we've moved on fantastically well, actually, in Northamptonshire around what the things we need to have in place for that. But having that amount of funds there, should we need it in a really emergency situation, puts us in a great position. Sarah, do you want to cover both what we're using that money for, but also any other good tips on trusted information that you'd like to share?
As Jane has already said, trusted sources, so UK HSA, government guidance, National Health website is amazing. So always, and we do have on our internet health protection page a list of trusted sources for people to use and to look at. With regards to our health emergency spend, the 2.2, it would be looking at if a major incident is declared, staff standing up, contact tracing, incredibly important, resourcing PPE once we know what the pathogen is, any additional PPE that we may use, the rapid stand-up of fit testing, so if people are required to be wearing FFP3 masks by law, they have to be fit tested. So it's all around doing those things, getting them in place quickly, making sure legislation and guidance is up to speed, working with our environmental health colleagues as well, because during COVID they were absolutely fantastic and helped me an awful lot with infection prevention control stuff. So it's all about preparedness. The things that we know from lessons learned that we need, and we need it now, they are the things that the 2.2 would be spent on, under the direction and authorisation of Jane.
Thank you. Any more questions?
Thank you.
Councillor Geary.
First of all, thank you ever so much for talking about the NHS as a source of information, because the quality of information that we're getting more and more of less and less. So thank you very much, and I'll note that. With regards to the demand placed on our services, you talk about the winter being an issue, and then you talk about it being more of a yearly issue. Can you scale the size of the winter issue in terms of percentages of more people that demands the services? And also, can you talk a bit more about the summer? You mentioned there about the possibility of new diseases coming along. I wonder if you can tell me a bit more about that as well, please.
Thank you, Councillor Geary. With regards to winter pressures, I think the most important thing to always bear in mind is that our patients will always have a higher acuity during winter season, because obviously we are starting to see flu really rear its very ugly head. COVID will present as well. We do still see those viruses during the summer, but not on the scale that we do see during the winter. So it's all about acuity. Bearing in mind as well, winter pressures, with weather changes, we will see more falls. So more people will be coming in with potentially broken bones and things like that, things that we won't see in the summer. But I think across percentage-wise, I can't give you a percentage without having to go to the acute hospitals to get that. But I think during the summer, we have, over the past few years, again, seen that higher level of acuity of illness within people. So we are an ageing population, but we're not an ageing population that are ageing well. So we will see people with long-term conditions, diabetes, cardiac issues and things like that. We will see that going and continuing through the summer, but it's also affects winter pressures because those people with those comorbidities, heaven forbid if they pick up a virus, will become more unwell. So it's all around the levels of acuity. But also I think it's things around demands of our ambulance service that all has an impact on summer and winter, demands on our front door. So I again go back to it is about levels of acuity.
There's another statistic as well, Councillor Geary, that you might be interested in, which is called excess winter deaths. So we look at how many more people have died in the winter than you would, compared to the summer months, and it is significant. So this is calculated on a yearly basis, and you can get it through the Office of National Statistics. But I think it demonstrates the fact that we are seeing so much more pressure in the system at that time of year. Partly it is because of bugs that we see more of, but also we know there's issues like fuel poverty, we know there's issues around the weather, for example, that also causes issues. So we have to anticipate as a system, and particularly a health system, that we will see more people through the door because of the time of year. And as I think what Sarah was saying is that whereas we used to do years ago, winter planning didn't need to take the whole year to plan for, we absolutely do need that now because the strain is significant, and they do model it. So the NHS will model based on what they've seen in Australia and various other things. What do we anticipate to see? January, February seem to be really crux periods actually for the NHS, and what they will do is they will anticipate that and think, what are we going to do if we don't have enough beds? So that is a really significant pressure. In terms of the summer months, I think one of the big concerns that is being seen internationally is if we see significant climate change, will we see things like malaria? So malaria is obviously the vector for that is a mosquito. And are we going to start seeing different diseases that we are not particularly used to as a country, that we would struggle potentially with compared to other countries where it's more prevalent? So it's about future-proofing and saying what could we anticipate seeing more of? How would we cope with that as a health and social care system? And I think we do have to anticipate a change in that profile if we look at the international picture around climate change.
Thank you, Councillor Geary. I'd like to ask something about specific groups that have not been offered vaccines this year compared to last year, like the COVID jab. It was offered to 65 and over last year, and at-risk groups this year it's 75 and over, and some risk groups have been left out as well. The other thing was the youngsters. You were saying about youngsters and is it HPV can never say that word, the virus, do you go out to schools and educate youngsters? Because young people are sponges for information, and that will remain with them for many, many years. Do you go out to the schools and educate them as well?
If Chair, through you, if I can take the second question, and then Sarah will talk about, because you're right, the who gets a jab automatically has changed, but Sarah can talk about that. In terms of school-aged work, so we have a school-aged immunisation service, which is actually a service provided by NHFT, so Northamptonshire Foundation Trust, and that will provide information for people as part of that. A couple of things they've tried to do to increase uptake, which I think is really interesting. One of them is an e-consent form. And one of the things I was thinking about when I saw this e-consent form is I can remember, my boys are in the 20s, but I can remember getting things back that I had to sign around consent and never being quite sure where they were. So one of the things that service has done is said, can we have an e-consent process which would allow that to be smoother, which I think is definitely helping. Overall, we've seen the number of people who aren't consenting for that jab go up in the last 3 or 4 years, so we want to make sure we make it as easy as possible. The other thing that the service has done, which I think is really interesting, is a needle-phobic pathway. So some people, some young people and some people generally really struggle with immunisations because they have a needle phobia. So that pathway has been developed, and it coaches and supports young people through that process of having a jab. That's really valuable in lots of different ways, because actually we know we're jabbed for a whole range of things, aren't we? And I have them all the time for B12, for example. So that's something else that they're doing to try and get the right sort of pathway and the right support for people. But also I think that one of the key things is we're going to be doing some work around what do people understand by HPV? What do they think it is? What do they think it causes? I still don't think if you stopped somebody on the street and said, what do you think just about all cervical cancers are caused by? I don't think everybody you speak to is going to say human papillomavirus. And it's really, really important that we get that message there. When we talk about head and neck cancers, people don't associate that with HPV either. So it's a piece of work as a whole, as nationally we need to do, but locally we're picking that up with our partners. There's a fantastic charity called Swallows, who do a huge amount of support for people who've got head and neck cancer, and they're doing some fantastic work in this area as well. So it's about getting the right information, answering questions in a really clear way. So if a parent does have concerns, we need to make sure those questions are answered well, and that it's easy. Because if it's easy to consent and it's easy to have that vaccination, we tend to find that is key.
I think, and also another really important point to follow on with what Jane has just said is relating to the actual vaccination itself. So when it first came out, it was given over 3 doses. It is now 1 dose, a Gardasil 9 vaccination, and it's 1 dose. So it also makes attendance a lot better. So that's something that's really important to know. With regards to the COVID vaccination cohort, so you're absolutely right, our over 75s, our residents in older adult care settings, and people over 6 months that are immunosuppressed are eligible for their COVID vaccination. The reasoning behind the changes in the cohorts is that during COVID, we naturally got population immunity, and it just increased because of we were in that pandemic. We'd also got vaccine, what we call vaccine-delivered immunity as well. So having the vaccine helped. It's now targeted to those groups because these groups specifically are at a lot higher risk of serious disease and sadly mortality than we are. So that's basically a little bit of the science as to why the cohort changed. I hope that answers your question.
Yes, thank you. Councillor Mundy.
Thank you, Chair. It's not a question really. I just wanted to go back on my point about misinformation and disinformation online. And just to reiterate something Councillor Geary said earlier, that the NHS, particularly for the people at home, is a fountain of knowledge and it should be used. Not only have you got the NHS 111, you've got the NHS website, which I've used before personally, and there's also the NHS Knowledge and Library Hub online too, so people at home know those options are available before you look on Twitter for your health information.
Thank you, Councillor Mundy. Councillor Duffy.
Yeah, I just want to go back briefly to something that Sarah said about the MMR2 vaccination now being available to 18 months from January. I'm sure there's an obvious answer here, but for children that are 19 months to 3 years and 3 months, do they all become eligible in January, or do they still wait for the 3 years, 4 months?
They will stay on the original pathway, so 3 years, 4 months, unless JCVI, which is the Joint Commission for Vaccinations, decide to do catch-up sessions, basically, and bring that vaccination forward.
Yeah, I just thought there might be people watching that
would absolutely.
Think, yeah.
Thank you, Councillor Duffy. Councillor Harrison.
Thank you. Jane, you were talking about HPV just then, and I didn't know those facts that you just told us. And I was just thinking, one of the biggest public education things that I remember from my life is in the 80s with HIV. And I don't think there's anybody in the country who wasn't aware of those of that programme back then. I just wondered if, because we don't see so much of that sort of national, centrally driven messaging. I know we all get our news and stuff from all sorts of different platforms now, so perhaps it's not quite as obvious. But I just wondered, it seems like such a strong message that, maybe that could do with a bit of some national messaging around it. You're probably going to tell me there is.
I very much remember. I can remember the advert. I don't know if anybody else can remember and I think one of the issues with the advert, if you can remember, it was a tombstone falling. And that it did definitely cement things into brains, without a doubt. And use of condoms, for example, in my sort of age group was pretty good, actually, because of those sorts of messages. So it does work. It can, though, of course, frighten people, and it can also be stigmatising. However, I think I agree with you that there is not enough visibility, particularly, I like to talk about HPV in any given situation, because I think you're absolutely right. There isn't enough visibility and people aren't having those conversations. What I'd like to hope is that when people go for cervical smear tests, for example, that this conversation is had then. I'm hoping, because there are things like leaflets in doctor's surgeries and things like that. But what I would say to anybody listening to that is interested or thinking, well, what is this? Again, the NHS website has a fantastic resource around HPV. And people don't need to remember human papillomavirus, it's just HPV. And that will tell you about how it passes between people, what it's linked to, how to get the vaccination. All of that stuff is on there. But one of the things I always say to people about HPV is, for a start, sometimes it is confused by people with HIV. It's very, very, very different to HPV. There are many, many kinds of HPV, and for most people, they don't cause any symptoms whatsoever. Okay? It's just that for some of us, we struggle to clear it, and for those people who struggle to clear it, it can become cancer. So the key thing to remember as well is that most of us will be exposed to it at some time. So, for example, there's been lots of interesting studies looking at people who are sexually naive, essentially, because it's skin-to-skin contact. And they have very, very quickly, once they've started to become sexually active, been exposed to this virus. It is everywhere, really. It's just something you come across. It's not something to be stigmatised. It is actually something that we just need to accept is out there. We need to protect ourselves as much as possible, and the key thing to do to protect yourself is to have the vaccination.
Thank you, Councillor Harrison. Jane, any other questions? Councillor McLean.
Thank you, Chair. Can we go back to the vaccinations itself? How do you approach those who have had a negative effect of vaccinations or feel that it's made them ill and they now feel that they don't want to take the next one?
I think Sarah wants to come in on this one as well. There's quite, people will have sometimes experiences that are not ideal, and it does make them worry not only about that vaccination, but sometimes other vaccinations as well. And that's definitely in the research literature. You can see that. The key thing is that we can't hold people down and jab them. I mean, we'd never do that. That's not ethical. So the key thing is to give people the information and the support. So, for example, particularly if someone's very vulnerable, or what some people sometimes forget is that, so for example, children are fantastic little vectors to pass things on to vulnerable people. So if people are worried about vaccinations, we often talk to them about, well, what was your reaction last time? How did you feel? What are your worries and what can we do to dispel it? We can't force anybody to have a vaccination. It's someone's right to say no. Of course, it's their right to say no. But we try and give them the best information that's possible. And even when it's looking at like school children, for example, and what they might pass on to other people sometimes forget that actually a child can be the difference between an older person getting the flu, for example, or not getting the flu. So we have those conversations, but we can't force anybody to have a vaccination. That would be completely wrong. But we hope with the right information and support we can overcome that. Sarah, you might have some examples of that from clinical practice, maybe?
So our outreach mobile vaccination unit obviously has trained vaccination staff in it. It has nurses and what we call MEC, so making every contact count. People will come into the vaccination van, have that conversation around vaccinations, their vaccination history, what have they had previously, what were their reactions, what are they scared of, how can we make this visit better for you? And it may be along the lines of just sitting there talking, being open, being transparent. They may sit there and say, actually, could I have my blood pressure checked first? So we'll get the blood pressure check done. Or can you talk to me about smoking cessation? It's about having that initial conversation, that initial feeling of trust. That conversation is in a safe place. The conversation and the information they receive is correct and from a trusted source. They then, within that 10 minutes of that conversation, go, actually, I feel okay now to have that vaccination. So it's all about having that trusted conversation, that being made to feel that you've been listened to, that we understand why you may be hesitant to have that vaccination, or go away and think about it. We are back here next week. Come back and we can go do this again.
Thank you, Councillor McLean. Any other questions? No. Okay, thank you, everyone. Going to move on to the recommendations. Sorry.
Chair, I think the next part of the presentation I'm leading on, it's about emergency planning and preparedness. So I'll be referring to slides 77 to 88 in your document pack. So in the first instance, basically just wanted to set out what is emergency planning. So as the slide indicates, it is has a focus on trying to reduce the chance of emergencies occurring, and it's all about trying to protect residents and the environment. And there's a number of key functions involved with emergency planning. So there's a large amount of risk assessment and planning involved to try and identify what the key risks are that we're facing in terms of incidents and emergencies and how we might plan for those going forward. So it's outward looking in terms of how it impacts communities, but it's also inward looking in terms of looking at some of our own services and how we provide those in the event of an emergency. So business continuity is a big part of that as well, in terms of we can try and maintain our own council key services during disruptions, and we've all got our own business continuity plans within services, and they're prioritised, so we know what services we need to recover first in the event of a major emergency. A large part of emergency planning is around multi-agency coordination as well. We need to work with other key partners around Category 1 and Category 2 responders, and I'll come on to say a little bit more about that. And it's also very important about how we train and exercise our plans and learn from that. You've already heard about some of the training and exercising we've done around exercise Pegasus, which is around our pandemic planning. But there's also a large amount of emergency planning. It's about trying to build community resilience as well, and trying to basically prepare our communities and residents better so they can self-serve to a degree in the event of an emergency and help manage that. And then there's the whole issue around the incident response itself and how we might manage that with our partners, and what we then might learn from that in terms of lessons learned, and the post-incident recovery, which is largely local authorities who lead in terms of post-incident recovery. So that's really what emergency planning is about, and that's what it is at its core. So the key legislation that underpins all of that is the Civil Contingencies Act 2004, and as I say, that sets out the context of emergency planning in terms of Category 1 and Category 2 responders. So Category 1 responders are ourselves as local authorities, the emergency services, fire, police, ambulance, the NHS bodies and the Environment Agency. And then you've got the Category 2 responders, the sort of main utility companies and transport companies. And the focus around that is around, as I say, risk assessment and contingency planning, trying to make sure that we've got emergency plans in place for all of our organisations and business continuity arrangements, that we have suitable systems in place for public warning and getting information out to actual communities and members of the public swiftly. And it also sets out how we operate as a multi-agency forum. There's around something called the Local Resilience Forum, or LRF. That's effectively where those Category 1 and Category 2 responders come together as a county across the whole of Northamptonshire to actually address how we plan and respond to emergency incidents. And we work towards some general principles around that, about wherever possible, where we've got an emergency incident, we will try and co-locate, we will try and communicate in a coordinated way, try and make sure we've got a joint understanding of the risk around the particular incident, and a shared situational awareness about what the incident is, where it is, what type of incident it is, what hazards it might present, etc. And sort of, what the sort of key issues are around numbers affected and sort of what emergency services are engaged. So that's slide 2. So in terms of those responses, I've said we work as an LRF, a local resilience forum, and essentially we're focused on a number of issues really that are identified in something called the National Risk Register. So that's a government document that is nationwide. It contains about 89 potential threats within that document, and they're largely grouped around issues such as terrorism, cyber, state threats. You'll have heard some about that in Parliament today, about state threats in terms of China, etc. There's also the whole issues around accidents and systems failures, things like Buntsfield and fuel disruption and power outage type issues. You've got the whole issues around nature and environmental hazards and risks in terms of wildfires, floods, extreme heat type incidents, etc., and human, animal and plant health type issues, things like pandemics in terms of COVID and bird flu and things, and foot and mouth and issues like that. So all of those are captured in that list of 89 potential threats. And basically what they are then looked at is we have risk assessments that look at those threats and see what significance they have in terms of a local context. And then they inform something like called the Community Risk Register. So that's effectively the risk register for Northamptonshire, and it sets out what we believe are our key risks for Northamptonshire, and those are largely around malicious attacks, cyber and fraud, serious organised crime, accidents and systems failures, natural and environmental hazards, human and animal health, and social disruption. So all of that information is on our website under emergency planning, so you can dig into that and have a look at that at your leisure if you're interested. So in terms of moving to sort of examples really around emergency planning, they sort of tend to be grouped into two sort of categories really. You've got your big bang type incidents where you sort of have sudden high impact events that occur with little or no warning. Generally the characteristics for those is they create immediate and significant disruption and they require rapid response and decision making from us as a system in terms of the LRF. So some examples of that are things like explosions, terrorist attacks, major transport incidents, major fires and collapses. So things like the 7/7 London bombings, the London Bridge stabbing, Grenfell fire, all of those sort of incidents that would fall into that sort of category of response. And then at the other end of the continuum, you've got the sort of slow burn type incidents. So they're the gradual escalating events that sort of develop over time, characterised by sort of less predictable, really, often not early detectable in some instances, and they do allow more time for us to plan and intervene in relation to those types of issues. So those are things like flooding, although that can be an immediate issue, but it tends to be over a little bit of a wider period. The pandemic or disease outbreak situations such as COVID, industrial disputes and things like prolonged power outages, etc. So just focusing, I guess, on two examples. In particular, I've heard a little bit already around Pegasus. Exercise Pegasus was, as Jane said, was a national exercise. And we were effectively in Northamptonshire as a system. We've sort of invited ourselves to participate in this exercise. So we've effectively played at a level in relation to this in a much more detailed way than most other LRFs and systems across the county. It was based on a respiratory type issue, etc. There was significant mortality involved in that scenario, etc. With thousands of potential fatalities in the first instance. And what we were looking to do through that exercise was test 14 of our capabilities that we've sought to plan for. So things like mass testing, PPE management, mass contact tracing, excess deaths, quarantine and isolation. They're just a few examples of the 14 capabilities we were looking to test. So for each of those capabilities, we had a planning lead. We conducted a tabletop exercise around how that impacted with respect to that capability, and we worked through that scenario in terms of the injects that were given throughout the exercise. And we obviously took the key learning from that, and what we'll be looking to do is have a system-wide debrief as a consequence of that and feed that both back into central government and our own future planning around pandemic. So I think as a consequence, whilst it was a lot of work for us at a local level, which should allow us to be ahead of the game in terms of our planning, in terms of any future incidents around pandemics. So that's pandemic planning and exercise Pegasus. I guess the other key aspect of winter preparedness that we often get involved in is around flooding. And there's an example in the slide deck there about what our response was in relation to flooding in terms of September, October 2024, what we called Operation Yeovil. We had some significant issues there in terms of above average rainfall volumes, large flooding impacts from surface water and from rivers. During that incident, there was significant flood damage to properties across North Northamptonshire and West Northamptonshire for that matter, and there was a specific focus around one of our mobile home parks at Yarwell Country Park, where we had to engage a multi-agency led evacuation there, and there was also significant properties impacted in the Grendon area. So what that enabled us to do was obviously test our response in relation to flooding and particularly, our responses in relation to setting up reception centres, emergency transport, welfare support to residents who were evacuated from the site at Yarwell Mill. And obviously there was a significant number of residents impacted. There was also wider implications around public health advice in terms of sewage contamination at the site at Yarwell. So obviously we needed to make sure that was addressed before it was safe effectively for residents to go back to the site and effectively go about their normal business. and obviously it's significantly tested our ability to respond over a period of time, because it wasn't just a couple of days. This whole incident ran for a couple of weeks, etc. So we've obviously taken the lessons learnt from that. We've built that into our flood management plans going forward, etc. And obviously we're feeding that into how we can ensure that we've got the necessary resources that we can stand up over a period of time going forward, and that's being built into sort of future arrangements around our flood planning. So I guess in addition to that, we also share that information more widely with other agencies that we engage with the LRF through lessons learnt, and that's all published through a shared learning platform called Resilience Direct, where all this information is shared amongst various agencies. So I think what I've tried to do there is just give you a flavour of some of the things that we are involved with internally and with other partners in terms of winter preparedness. So I'll stop at that point, and I'll be happy to take any questions people have got in terms of the emergency planning aspect. Thank you.
Councillor Harrison.
Thank you. Thanks, Ian. That was really interesting. And I was particularly interested about Pegasus and the process that you've been going through there. And I was interested particularly in the fact that the scenario that you've been working through is a respiratory illness again. And I can understand that. You know, we've got flu, SARS, COVID, and I'm guessing that the thought is that the likelihood of another pandemic would be another respiratory illness, but there must be a possibility that it's going to be a very different type of illness that's transmitted in a different way and has completely different symptoms, but nonetheless devastating. So I guess Pegasus, I wonder if it's just trying to consolidate on what we've already learned to make sure we absolutely understand how we would deal with something that might be in any way similar to COVID or flu. But I guess, you know, it'd be good to know that, you know, what sort of planning and thought processes are going around. You were talking earlier on about looking at some of the illnesses that could be coming our way that we, you know, aren't used to having in this country. It'd be interesting to know, you know, sort of how you're sort of identifying what else might come and hit the UK at some point in the future and be a pandemic that's not like these. Sorry, I'm struggling with explaining things tonight, but hope that made sense.
If I can just provide a general response, and then I think Jane's going to sort of go into some further detail around some of the planning, I guess. In terms of the pandemic plan that we're looking to develop, yes, obviously it will be informed and the lessons will be taken out of the Preparedness scenario, which was a respiratory infection. But the pandemic plan is intended to be able to respond to any pandemic situation. And obviously, yes, you know, there could be various other different forms of infection that might feed into that. But I'm going to let Jane maybe give you an indication of basically some of the scope of that and some of the thinking around that.
So it's really interesting, Councillor Harrison, because we knew that there's going to be a made-up disease, because this is an exercise. It's make sure anybody listening at home, this is an exercise. It's not real. It's a made-up situation. And we were thinking, what could it be? What could it be? The example they actually gave was a respiratory transmission, but also fecal-oral as well. So it also could be passed through people not washing their hands properly, etc. It was quite a bit complex. It was a bit of a complex old do, wasn't it? And also it was very different in terms of who it affected. So this particular situation that was part of an exercise, which I keep saying, really affected children, for example. So it was quite different from what we'd seen before. But Ian's point is really important. Our pandemic plan, which we've exercised through the exercise, so we've trialled it, we've found some things that have worked really well, some things we want to tweak, that should be applicable to just anything, really. I think the key things that I would say that I think we've got some real strengths around, we very quickly were able to say, how would we stand up contact tracing? How would we stand up all of the things, all of those capabilities that Ian's mentioned already? So the principles are the same. Obviously, what nobody wants is some sort of horrendous, catastrophic disease. And Ian and I when we were preparing for Pegasus, we're almost taking bets on whether it might be something called a viral hemorrhagic fever, which is things like Ebola. We're thinking, oh gosh, could it be that? But it wasn't. So it's impossible to say what it would be, and it might be a completely novel virus. But what I would say is any good pandemic plan should be applicable to any situation. And the key bit with the pandemic plan is locally how well is what's called our local resilience forum, which is all of the partners coming together around emergency planning. How good are we at working together to do things at pace that are robust and systematic and that really limit the harm of that to the population? And I think this exercise has shown us that we have some real areas of strength actually locally. Some areas we need to work on, of course, that's the whole point. But it's definitely been a worthwhile, if not exhausting, process. So, yeah, difficult to say what would be coming in summary, but the plan needs to be applicable to all conditions.
Thanks, Jane. And if you'd have taken part in Pegasus prior to going through COVID, do you think it would have been much harder? So what I'm saying obviously is, you know, there must have been a lot of learning that came from going through the pandemic, and hopefully that meant that all sorts of things had been practiced and tested in the heat of the moment, that hopefully now becoming much more like a part of, you know, something that we all recognise and know and understand and can bring into action, rather than having to relearn, you know, all of it and start all over from the beginning.
Absolutely is the answer to that one. So, I mean, that was completely unprecedented, really. So, lots of learning, and there's obviously the COVID inquiry that's going on at the moment. So that information with the exercise Pegasus brings together nationally as well as locally a really good sort of set of information and lessons really that we need to learn from that. I think some of the things that came up through COVID that, you know, the exercise also looked at is how do we work with the population who've been through this already? Because obviously when we went through COVID, most people couldn't remember a thing like that before. If it happened again, which it will happen again, that's the way that pandemics unfortunately work, is we will have had all that history and all that knowledge. And some of that's really positive, but some of it isn't. Some of it is, you know, will people want to self-isolate? Will people want to do the distancing, etc.? Because actually, when it comes to infectious disease, a lot of this is pretty standard, really. So that's an added complexity, and it's something that nationally that's being looked at, isn't it, Ian? Is how do we make sure that people... We've learnt from COVID, but we also learn how might we do things differently next time, and how do we get the information out there so that people do follow the guidance that they're given.
Thank you, Councillor Harrison. Thank you, Jane. Can we go to a vote, please, to extend the meeting until about 9:30? Those in favour?
Yeah, thank you, Chair. Just to clarify, we're extending the guillotine to 9:30.
Yeah, we'll go about 10:00.
Councillor Howe.
Just on the Pegasus exercise, is there anything that you can share with the committee on sort of findings or a report on the exercise? Because I'd be quite interested to see a bit more information about that, if possible.
So it's literally just finished. So not at the moment. So what we're doing locally, so nationally there'll be learning around that. So every time we went through part of the process, so Tyler, who's in Ian's team from emergency planning, he would write a really detailed report about what our experiences were, and I would sign that off, as would David John, who's my equivalent in the West. And that's all gone back into national, so it's a huge piece of work nationally, actually. Locally, we're also saying what are some of them are communication things, actually, more than anything. Who do we go to first? Have we got the right people around the table? So at the same time the national work is being done, we're also doing a lot of local work around what have we learnt from this process. So, I mean, what could be a suggestion by the committee, for example, is that we come back in a certain amount of time and say this is what we learnt and this is what will change as a result from that. There will be things that will change, but that I've also felt some assurances actually on some of the ability for the system to stand up, and I do feel that we have learnt a lot from COVID, but we can come back and share that.
Thank you, Councillor. Councillor Mundy.
Thank you, Chair. If I just cast your mind back a few years, we had a situation where the UK effectively ground to a halt because of heavy snowfall. I think it was due to not having enough grit available. So I'm just thinking, particularly as we approach the colder months, and we are seeing more and more extreme weather events, have we got something in place, considering obviously our more rural communities, to reach stranded people in the event of a large amount of snow?
Yeah, that sort of severe weather event, if you effectively did have a significant number of motorists, for example, stranded, etc., on a road, then obviously we would obviously deal with that in terms of our normal emergency incident response, and we would be able to respond to that, I think, reasonably effectively as a system with other LRF partners. You also sort of like referred to issues around grit. I mean, obviously, again, this is business as usual for highways colleagues in terms of dealing with gritting of the highway routes. So over the winter period, in terms of, you know, they're well versed in terms of doing that and are plugged into all the weather data that they need, etc. We'll have full stocks of grit, etc. at this point in the year, because I don't believe we've actually done really any significant gritting so far this year. So, I mean, that really, for us, is business as usual, those types of issues. So I wouldn't have any concerns that we wouldn't be able to respond appropriately to those types of issues.
Thank you very much.
Thank you, Councillor Mundy. Councillor Duffy.
Yeah, could I just ask Ian, in light of the floods that were mentioned in Grendon, I think it was Operation Yeovil, what has the council done to strengthen its procedures or learnt from that, changed, just in terms of reading the documents there, everything seemed very reactive and quickly reactive, but what have we done proactively? Is there outside agencies, the Environment Agency, etc., so that the same amount of rain next year wouldn't cause the same amount of damage? Are we being proactive, changing what we do year on year?
There is an element of proactivity involved in this, but there's also always an element of reactivity, because you can't predict where the rain's going to fall and where it might effectively impact, because you can get freak cloud bursts in terms of thunderstorms that can hit particular areas, and that's what we were concerned about with respect to the rainfall last week, etc., in terms of that storm front that came over. We were led to believe we could have up to 80 mil, but thankfully we didn't. We got up to 50 mil, and it fell steadily throughout the day, and it didn't cause the problems that we anticipated it might, but it could have been a very different picture. So I think the whole prediction of where flood events might take place, both in terms of surface water flooding and river water flooding, we've got much better data around that now, and the forecasting of that, which is largely done by the Environment Agency, is much more effective than it was years ago. We've also done quite a lot to work with local communities that regularly effectively experience flooding issues to try and build their own resilience and flood resistance within the community in terms of response. That could be as simple as effectively making sure you're looking after the older people and checking that they're okay, and other people who are vulnerable in those communities, and they know who they are. They can take their own action as well in terms of potentially putting some sort of flood prevention measures in place in relation to their properties. And there is a certain amount of funding that's available to try and work with local communities about improving flood resilience and prevention in communities. So it's a combination of measures, both in terms of obviously proactive measures plus the actual reactive measures in the incident itself. But given the sort of level of frequency of these incidents, our ability to respond to them is sort of reasonably well rehearsed now, etc., as a system.
Thank you, Councillor Duffy. Councillor Pengelly, were you? No. Anybody else? Councillor McLean?
Yeah, I think any time you're going to design a synthetic exercise, and as Ian was saying there was like something like 80 odd scenarios you were talking about. So you had all these specialisms coming in to make this synthetic exercise work. Now, one of the things you would need to have going in there, you would need to know that each specialism had the assets available to carry out the real thing. Do you know what assets you have available and all these other departments, or is it just a sort of guessing thing? We may have these assets available if it happens.
Through you, Chair. So if you're talking about exercise Pegasus as an example, so part of that would be looking at capability. So the capability, all these work streams that got set up and stood up underneath it, would be saying, in this situation, how would we get PPE? Now, for example, let's take PPE as an example, because that was such a huge thing, wasn't it, in COVID, and we all know that. So there's been quite a lot of work gone on since COVID about stocks of PPE. We're in a slightly different position, I think, than we were prior to COVID. So part of the exercise is that assurance bit of saying, what would we do, what can we do, and where are the gaps? So obviously with PPE, people will remember that a key issue we had, and I'm sure, David, you can probably remember this, is that in COVID, PPE wasn't available very quickly, and it also wasn't available to potentially all of the people that needed it. So health care had a supply. It did get to social care, didn't it, David? But that was a little bit trickier at times. My personal area of responsibility was homeless shelters. And where I worked there was a lot of people in that position. How do we get PPE to those workers? So there was all of that sort of focus. So we know we can anticipate some of the issues, and we can ask all of the organisations to have really clear plans for what they've got and what they might need that's additional. Again, it depends on the situation. We don't know what's coming, but we can only be as prepared as we can be. But all of these exercises mean that we have to be at least thinking about that and looking at what we've got and looking at where our vulnerabilities might be.
Yeah, so what I'm saying is then, if it happened tomorrow, you don't have the assets in place to deal with it then?
We do have a very good asset base for lots of things that we would need. So, for example, some things we wouldn't have. If it was a completely novel virus, we wouldn't have a vaccine. That's not up to us to be able to do that. But what we would have is a really good way of mobilising that vaccine when it's available. So that's the sort of thing. So assets are not just things, they're also the way the system would come together to solve that problem. And I think what we're seeing through the exercises, we're in a pretty good place, actually, in relation to those particular areas. And certainly a lot further on than we were at the beginning of COVID. There's been a lot of learning in that time. So there's each part of the system has specific staff that look at this. So the health system, for example, have emergency planning experts like Ian in their particular area, and they work together to make sure that we understand where those vulnerabilities are, or we know where the strengths are in the system. It's actually emergency planning is a really interesting area because it is extremely process driven, which is great because I love a process, Councillor McLean, it's one of my things, but also it means that there is very clear areas where we could say, right, if we needed PPE, this is where we know it is, this is where we know the vulnerability areas are. So it's much more about making sure that we have the right plans in place that can be mobilised quickly. Some assets would have to come from national, so we'd have to have, if we have a supply of PPE, for example, if that runs low, that is when the national picture that comes in and says this is where that supply is coming from. But locally, what we're testing is our ability as a group of police, fire, health, voluntary community sector who are really pivotal to that, local authority. How do we work together to deliver the right thing at pace to keep vulnerable people safe?
So was the exercise just solely based on a respiratory outbreak then? There was nothing else?
It wasn't just respiratory. It was also, without wanting to go into too much detail about it, it was a potential virus that could be passed on between animals and people. It could be passed on through lots of different routes. So it was tricky. And it also, this particular exercise, which was not real, had a high mortality rate, much higher than what we've seen before. So it was pushing the system quite hard into something that would be a very difficult situation to deal with. You're always best to exercise on a really worst case scenario.
Thank you very much, and thank you, Jane.
Thank you, Councillor McLean. Any other questions? No. Shall we move to the holding recommendations? First one, system-wide coordination and review. It's recommended that the committee receives a joint update from Public Health and system partners outlining outcomes of the 2025-26 winter period, including lessons learned and key improvements in multi-agency coordination. 2, targeted vaccination and inequality monitoring, and it's recommended that an update be provided to the committee by June 2026 on progress made in addressing low vaccination uptake among high-risk or underserved populations, including evidence of outreach activity and impact. 3, emergency preparedness and climate integration. Recommend that the Council's next annual Winter Preparedness Report 2026-27 includes a section on climate-related resilience and mitigation measures, and that this is brought back to the Scrutiny for review ahead of 2026-27 winter session. Can we take a vote on? Do we take a vote on that? Yeah. Can we have a show of hands? Okay, any proposed recommendations on top of that? No? We okay? On the wrong bit. Is it on the wrong one? All right. Oh yeah. Going to hand over to Raj now.
Thank you very much, Chair. So the next meeting of Health Scrutiny is scheduled to be held on the 6th of January 2026. As always, items will go through the Scrutiny Management Board ahead of this meeting, and the exec forward plan will also be looked at to see what we can add to our forward plan. For January, we currently have the ICB down to come and give us an update on GP performance and availability and dentistry. And yeah, as always, we will take into consideration anything the Scrutiny Management Board feeds back to us for consideration on that agenda. Thank you, Chair.
Can members note the contents of the work plan for the forthcoming meetings of the Health Scrutiny Committee? Show of hands, please. Thank you. At this stage, I'm going to close the meeting. There being no further business, I'd like to thank everybody, members and councillors this evening. And we'll close this at 9:30? 9:06. Thank you.